I work on computational medicine, and that is the application of computational methods in medicine. And really, when it comes to the specific computational methods, I use things from all areas of computer science. I'm a computer scientist by training, and I take things from algorithms, from human-computer interaction, and obviously from various aspects of AI, machine learning, natural language processing, depending on the medical data set that I'm working with. The most exciting thing about it is that the methods you're developing are making an immediate difference for patients. Some of the software we've built is already in use clinically, not just here at Sick Kids, but actually around the world. We have installations of a previous piece of software that we've built over the last several years in the UK, at several hospitals there, and several hospitals in the US, and it's used very broadly in Canada, pretty much at every single major hospital which has a genetics department. My research is a lot on the interaction between computational methods and rare diseases. So rare diseases is one of those things that sort of is not very prominent in the public mind, but actually there's over 7,000 rare diseases, and together they make up something around, there's around 1 million Canadians who have them, so it's around 2 to 3% of the population who develop a rare disease over the course of their lifetime. A huge fraction of these diseases are pediatric, so they're seen in children's hospitals like Sick Kids, and a huge fraction of those have an extremely severe impact on the patient's life and on the likelihood of survival and the quality of life that they have. So we work a lot on methods that take patient genomes and try to analyze them and uncover the cause of the disease, find the mutation. And finding the mutation that causes the disease is the first step towards treatment. And in many cases, finding the cause of the disease is treatment, because what we can do is we can give counseling to the parents around what is the likelihood of the disease recurring in their kids, in their future kids, and also give them information about how the disease is likely to progress. So that's sort of what makes me excited about being at the hospital and what really keeps me motivated. In terms of the work that we're doing now, a lot of it is moving towards actually helping capture the clinical data. Because one of the things that I figured out about genomics is that genomics is a lot of data, but it's actually pretty easy data because it's very linear, and capturing a genome, it's expensive, but you can do it. Capturing what's actually wrong with a patient is it's fuzzy. There's no hard, you can't just say you have disease X. Well, disease X is simple, but you can have a flu and you can have, you have a fever, you may or may not have a runny nose, you may or may not have any of the other constellation of features. And actually capturing what was actually the phenotype of the patient, the features of the patient, is the more complex task. And this is what we've been trying to do over the last several years. Obviously, they're going to grow. There's a lot of controversy to what extent black box method may or may not be usable in medicine, but I think it's just a question of clinicians starting to become more comfortable. Clinicians use a lot of black box methods already. It's just that they don't realize that they're black box, or that they don't realize that they're black box to them, but they just trust it because it's been used for so long. So, one of the examples I like to use is MRI machines. The average clinician who orders an MRI and then reads a radiologist report has no idea about the physics of MRI machines and how exactly imaging works, what exactly the MRI machine is measuring. In fact, it's actually measuring water molecules and protons, specifically in the water molecules. That's something way beyond their level of abstraction. What they care about is, what's the actual problem the patient has? Is there a torn ligament in the knee? Is there some deterioration of specific component of the brain? Is there a tumor that you can see on the MRI? So to them, the MRI machine is a black box. So it's a matter of getting the clinicians to the point where they're comfortable enough with black box technology, deep learning black box technology, that they sort of trust it intuitively without really having to think about it. But I think one of the biggest challenges in terms of deploying it is going to be human factors. How do we deploy computational methods without overburdening clinicians and without making the clinician a slave to the method? So making sure that the clinician, if the method is meant to be advisory to the clinician, making sure that the clinician doesn't trust it implicitly. If the method needs to be some kind of an alarm, that it doesn't go off so often that the clinician just goes on and starts to ignore it. There's many examples of bad technology deployments in medicine. I would argue most electronic health record systems that exist today are examples of bad technology in medicine. And this is going to be one of the biggest challenges, how to get the implementation details right, not just sort of say, here's technology, go run and use it. You need to really get the human factors correct as well.